Stressful part of my day is right there, just making sure it works. Thank you. It's a pleasure to be here. It's really a great pleasure. Sorry, sort of on the right slide. It's an honor for the opportunity to just be here. We've got a long history between the two sites, not too far away. Probably not as much currently as we should, but there's a strong history. One thing I wanted to say about Dr. Judd was consistent with surgical need to make decisions quickly. He finished medical school, was first assistant with Dr. Mayo, and the next year they appointed him to the staff. That's pretty quick. They saw something in him, and as was mentioned by Dr. Adams, amazing surgeon. We have at Judd Hall, we also revere. And he was the first partner that the Mayo brothers hired. So they had lots of visitors. It was an honor, and I'm sure it was because of his excellent training in medical school that made him so great. So I'm going to talk about laparoscopic pancreatectomy. I want to talk a little bit about the development of it, a little bit about the current status, and then maybe some future directions. Auto advancing there. In terms of, there's lots of procedures that can be done on the pancreas, but distal pancreatectomy and the Whipple, if you look at both those were both started. It almost worked perfectly. Not sure why it's auto advancing, but we'll get there. I'll talk faster. 1994, distal and Whipple were both described, and
You wanted the students to keep turning it back?
Gosh, I'll keep my finger on the button. That's going
that,
to give us a seizure here. But so, laparoscopic Whipple described in 94. In 97 was the first real series, and it was 10 patients. Dr. Gagne, 10 patients. They converted 40%. 4 of the 10. Operative time was 8 hours, and their conclusion was that while this is small, there was no benefit. And while I know that not everybody in this room is going to do pancreas surgery or wants to do pancreas surgery or HPB or oncology, I think it's a great story for me to share that this happened when I was an intern. And I have no idea why, but when I read this paper and saw that there was more and more laparoscopic surgery being done, this just set a burr in my saddle, so to speak. And all they wanted to do was prove that lap Whipple was possible. I spent my whole career doing that. So at the end of this, please just agree with me that it's... You may disagree, but it's been an amazing run. But the reason why I bring that up is, especially to the residents, you're all very bright people, or otherwise you wouldn't be here. If you have something that just really fascinates you and you have a passion for it, go for it. Especially if people tell you it's not a very good idea. Now be careful, because you have good mentors who'll try and steer you from 20 years of wasting your time. But at the same time, many of the things that we've seen progress in surgery, liver resection for colorectal mets, whatever. I mean, at the time it was introduced, it was crazy, terrible, and you shouldn't do it. So when I expressed this desire during residency, and they eventually offered me a job down at Mayo, they were not very excited that this is what I wanted to do. They didn't want me to do that. And I kind of went for it anyway. I could have just as easily failed and not been here today. But I just want to show that if you have a passion for something, just go for it. You will probably be the person that makes a big difference. So there's been gradual progress with pancreatic surgery, minimally invasive for sure, distal pancreatectomy and drainage procedures, fry procedures, things like that. Whipple, hybrid approach, laparoscopic, robotic, and then onward to more complex things like major venous or arterial resection we'll talk about. And really, in my opinion, there's almost no limitations. And I'll tell you as an example of that, every single patient I see with a pancreas problem, other than maybe 1 out of 200 or 300, I take to the operating room with the plan to do a laparoscopic. I do convert a few, but it's pretty uncommon. It's probably 2%. So it's possible. Whether it should be done or everybody should do it is a whole other story, but it's possible. And I think that sets the stage for the next generation, which is robotics. And then what's after robotics? We need to establish those. So my road was one probably a little bit less traveled. These are two of my mentors. Probably remember Mike Starr very well. Very encouraging in pancreas, but he and my other mentor, Mike Farnell, not so encouraging in laparoscopic Whipple. They came around with time. First Whipple at Mayo was done in 2007. It was when a presentation at the Pancreas Club in 2009 happened that I both got beat up by those who thought this was dangerous, should not be done, it's not a cancer operation, it's great if you're doing it for benign disease. That also sparked me to kind of keep pushing forward. I was actually doing cancer at the time, but then just to show them, I started doing vein resections, and I showed them that. And they said, well, that's fine, but you're handpicking, and what about the outcomes? So then we published a series on laparoscopic versus open for cancer and showed all of the same advantages that almost everything that's ever been done with minimally invasive surgery has shown: less blood loss, quicker recovery, those kind of things. Is it a better operation? I don't know. In my opinion, I think it probably is, but that will be like trying to determine whether 2 different chemotherapy agents is better. It'll take 10,000 patients and probably our lifetime to sort that out. Is it an option? So almost hitting 1,000 lap Whipples at Mayo now, over 100 totals. And then vascular resection is really kind of where things have gone the last decade or so. And that's not necessarily just to keep proving points or doing things, but that's what pancreas surgery has become. At Mayo, about 20% of our patients that we do pancreas operations on need a vascular resection. We're just seeing very borderline or advanced, locally advanced pancreas cancer now. The straightforward stuff is going somewhere else. The outcomes are good. I mean, every time I see this kind of data, the average time of 6 hours, I know everybody that does open surgery is like, oh my gosh, we can do it 3 hours. Well, these are 3-hour Whipples for the straightforward ones and 6 to 8 or 9 hours for the vascular resections. They just take longer. You see here, this was about 18% during this kind of 10, 11-year period. But the outcomes are very, very good. Not good enough. We want to make everything better in pancreas surgery, but they're good. I could show you a half hour's worth of data. I'm gonna bypass that because I think it's important to know that there has been so much data, not a lot of randomized controlled trials, some, but there is just endless series and multi-institutional evaluations of distal pancreatectomy, total pancreatectomy, Whipple, and all of the advantages, the typical MIS advantages are there. Less blood loss, less pain, quicker recovery. Oncologic outcomes are very similar. It depends on which study you want to look at. Some say better lymph nodes, some say not. I don't know that that's going to be a very clear outcome of this anytime soon, but as long as it's the same from an oncologic outcome and you get some of these other advantages, I think that makes it very important to consider. Instead of showing you all of the trials, just to know how much this is talked about and evaluated. The community has tried to be very careful with this. Not a big fan of endless consensus conferences, but they are a review of the literature and then people getting around and putting their opinions in. So it's still not perfect data, but it's just every other year, and they're not any different. Every one of these papers is the same. Minimally invasive benefits. We need more studies. We need registries. It's the same sentence you see at the end of almost every paper in surgery. This just shows the randomized controlled trials, all the data, everything from distal pancreatectomy to Whipple. And again, initially against open, then it was against robotic. And I think it's important to continue to do these, but the outcomes are not, or the outcomes of these studies are really not changing what we already guessed. A group that's very a big proponent of robotics did this meta-analysis of all the randomized trials for Whipple and showed that less blood loss, longer operative time, shorter hospital stay. And then when they concluded, I'm sure it was very hard for them to write this in paper, but better outcomes in laparoscopic and compared to robotic and open. And then they give you three sentences of disclaimers about any more studies, and it may be wrong. The point here is I don't think it really matters. I think there are advantages of minimally invasive approaches. I'm a big fan of that. But honestly, I think what's more important in this, in the pancreas surgery, is that whether it's robotic, laparoscopic, or open, it's done well, and the complications are minimal, right? I mean, I feel for the complications we all do when we have a bad one, makes us second guess why we chose pancreas surgery, but it's important. I can't ever get talking about minimally invasive pancreas surgery without taking at least a little bit of a shot at the robot. And I want you to remember at the end, I think robotic is going to take over. However, I totally understand why we're comparing minimally invasive approaches to open, but I still can't quite understand why we're comparing laparoscopic to robotic. And the studies are all over the place. Some show there's no difference. Some show there's advantages for laparoscopy, some for robotics. And I think they're all flawed, to be honest with you. For Whipple, there is nobody that has done a randomized trial that can actually do both, right? So what we do, even for distal pancreatectomy, most of the series are people that have done laparoscopic distals as their learning curve for 5 years. Then they transition to the robot. Then they compare the robot versus the laparoscopy. And I'd be shocked if it wasn't a little better because you used up all your learning curve for the laparoscopic group. So it's my bias, but the data is mostly flawed. The other thing is if you go from open to laparoscopic, or if you go from open to robotic, there is absolutely no question in my mind it is much easier to go to robotic than it is laparoscopic. When you're sewing a 2 millimeter duct and you're doing all these things, it's easier, it's intuitive. I mean, probably the smartest thing they ever did was call themselves intuitive, but it is more intuitive. So it is easier. So there's no doubt if a surgeon who has no or minimally invasive experience wants to get into this, I would definitely say try the robot because I think it's easier to adopt. I was in a different world where I did bariatric surgery for 10 years while I was doing my HPB. At Mayo, it was you did HPB and then they gave you an offer. You could either do bariatric surgery or breast surgery. And I went with bariatric surgery because I knew I'd be sewing a lot, which would help me with my goals for minimally invasive. That doesn't really exist now. There's not too many HPB surgeons that gets to do, 1,000 gastric anastomosis to get the training. So robotic is a little better. I want to give you just a little fun picture of how I see this. Open surgery, I'm sorry for all the open surgeons, but open surgery is like the horse-drawn carriage. Comfort is poor, but will it get you where you're intended to go? Absolutely. Will you forget the ride after a while and be just as good as somebody that went another way? Sure, that's totally fine. But the appeal is kind of poor, especially in our world. Laparoscopic, until I grew up in the 80s, I like Camaros, and the comfort's improved, the appeal's improved. It's a way better ride, and it's a fun ride. Well, you know the difference? Well, yeah, if you're feeling every rut in the old dirt road on the horse-drawn carriage versus the slick highway going 120 miles an hour in a Camaro, it's going to be a different experience for you. And robotic I see as still just a car, but the comfort's better. But what I want to ask you is, who's the comfort for? The passenger, okay, has some comfort, but let's say the passenger falls asleep. They're dead asleep. They're so tired, and you're driving. Let's say they're so asleep that maybe they don't even have muscle twitches.
Definitely have those.
Who is going to, do they know if they're in a Camaro or an Audi or anything else? Does the driver? Absolutely. They got power windows, power seats. They don't have a cassette player anymore. They have Sirius radio. I mean, they've got everything they need to make it a pleasurable experience, which is good for the passenger because maybe if they're more comfortable, they're going to do a better job along the way. All three methods get the passenger from point A to point B. Automobile allows the driver and passenger more comfort and safety. The luxury sedan adds all the gadgets that help the driver. If the passenger was asleep and paralyzed, would they know the method used? So this is where I go back to, I'm not sure we should be comparing laparoscopic to robotic. We can, but it's just more and more of those studies aren't going to help. Everybody's going robotic. Laparoscopic is 2D with sticks. I get it. It's not going to survive. But there's clearly a difference when you think about it this way. So it's for the surgeon. I don't have a problem with that because if the surgeon can do something robotic and offer a patient a minimally invasive procedure, awesome. That means a lot to me. So there's challenges. I won't go into this. I've kind of harped on this a little bit. Patient selection is horrible, absolutely horrible. If you talk to open surgeons in major centers that treat pancreas cancer, for instance, they're going to tell you what percentage of their patients need a vascular resection or all of these different things they need to do. And if you look at most of the series, nearly all, but most of the series of minimally invasive, it's not vascular resection. Or if it's vascular resection, it's just they stapled the portal vein, which means it was barely touching it in the first place. Otherwise, you wouldn't be able to staple it. To me, you can say what you want about matching. That's not the same situation. Time period I mentioned, early experience versus late. And surgeons, laparoscopic experience, and then you go to robot. There's also just differences. There's great HPB surgeons that just don't have a lot of MIS skills. It's just not how they were trained. There's nothing wrong with that. It's just a reality. So you just need to be careful with the studies. And then hospital resources. Not every laparoscopic setup or crew or even robotics is the same. I want to shift into the future direction for minimally invasive pancreatic resection, and I think really that's borderline and locally advanced pancreatic adenocarcinoma, because pancreatitis isn't really changing. It's still what it is. It's still what it was. But cancer has changed, and the reason why it's changed is because we've got better treatment. People that had borderline or certainly locally advanced cancer, when I first started on staff, I mean, we would give them, if we gave neoadjuvant therapy, nobody came back, right? So we were still operating up front and then hoping with adjuvant therapy we'd make a difference. And we made some difference. But now that, the last decade and a half or so that we've got better agents, we're seeing people come back and have somewhat stable disease. So that's really focused pancreas surgery more and more on vascular resection. When I was in training and early on staff, an arterial resection, maybe an occasional hepatic segmental, but SMA resection was taboo. I mean, the Japanese had published, the mortality rate was 30%. Not many people were doing that, but venous resection was becoming more and more common, and so we did a lot of that. And the morbidity is not necessarily a lot different for venous resection. For arterial resection, it's still quite high. 4, 5, 8 times as high as morbidity or mortality, I should say, than no arterial resection. But the oncologic outcomes are pretty impressive, and we've got a growing experience with better and better data with that to suggest that. So if it's good for open, why not laparoscopic? Well, I want to talk a little bit about that for a while, just to give you some fun videos, but also just to show you what's possible, but in your own specialty, whatever you choose, I think we should constantly be pushing the envelope, because that is how we make advances. Safely and organized, but push the envelope. Preparation, the big thing is reduce clamp time. Any open surgeon that does vascular resections would say the same thing, but I can tell you minimally invasive, it just takes longer. There's just no way around it. I've done quite a few now, and it still just takes longer than open for the vascular. So you need to do everything you can to reduce the clamp time. It's really important because it is a bit longer. So we make sure everything's ready, similar to an open case, but make sure everything's ready, including the dissection. You got to have all the right equipment. When I first started, when I learned open surgery, we always put a bile duct or a bulldog on the transected bile duct so you didn't spill bile in the belly. And so I was doing that first Whipples, and then after a while I thought, rather than convert this one that needs a vein resection, how about I just take one of those and put on there? And so it's the same bulldogs. We found this company that Ascalap that makes them for laparoscopic, but we use those for vascular sections. Exposure is peripheral to central, so that's why some of these arterial or venous resections take longer. It's not so much that the actual arterial section is adding hours, but it's the way we dissect, trying to come in to make sure we've got complete exposure so that the clamp time is short, and then we can do the vascular section. But we do all of the dissection. I'll talk about it in some of the videos. All of the dissection except for the vessel involved. All of that has to be complete, and then we'll clamp. So the only thing we have to do is transect the vessels, move the specimen out of the way, still in the abdomen, and then complete the vascular section. The problems with minimally invasive approaches, especially for vascular section, every centimeter of the trocar placement makes a difference when you're trying to work in a narrow place on a very soft artery or vein. As you know, when you have bleeding in minimally invasive surgery, it sucks because, right, the blood absorbs the light, you suck, you lose your pneumoperitoneum, somebody tries to help you with the bleeding site, they make a bigger hole in the portal vein or whatever. It's just, you have to be really ready. So venous reconstruction, lots of different ways, the same ways we do open. I would say similar to our open experience, end-to-end is by far the preference for a vein resection. If we can pull that together, we will. If not, we'll use something as an interposition. We typically use a lot of left renal vein, as long as the gonadal vein, between the gonadal vein and the IVC, there's at least 3 or 4 centimeters of good usable vein, we'll use that. And then occasionally, especially in the setting when we have to do a total pancreatectomy, and occasionally even for a Whipple, if they're a low risk for a leak, we'll use synthetic interposition graft. And then what I did for a long time, I do it less now probably, but if the vessel, the vein is involved across the confluence of the splenic, we'll do a patch. That way you don't have to transect the splenic, but that requires that there's less than 180 degrees involvement of the vein so that you can put a big patch on there. For arterial, that's also vein interposition, cryopreserved allograft, synthetic. A lot of times when we do arterial resection, certainly SMA, it is a total pancreatectomy. In case I forget to say it later, we decided that the SMA resection was 10% mortality, which was just unacceptable. And we found that almost all of those patients bled after either a very obvious clinical pancreatic leak or probably a subclinical one, and then you get pseudoaneurysms and you bleed out. So we started doing total pancreatectomies whenever an SMA resection is required, and some do it if even common hepatic. And the mortality rate dropped in half, went to 4 or 5%. So that was a simple fix. There's lots of ramifications of that, of course, but it allows us still to provide that. I want to show you some case presentations. Here's a case locally advanced. You can see the vessel. You can see here, it was actually fairly short segment, a little over 180 degree involvement. I was able just to do a small segmental resection of the SMA and bring it back together. This patient had a total, and so I didn't mind putting in a long interposition graft. While it wasn't involving the SMA much, it was involving about 8 centimeter length of the portal and superior mesenteric vein. So you'll see that. Here's another one. Major involvement, celiac axis, common hepatic, I think portal vein. And so here's one where we did, again, if I do a total, I don't always do synthetic, but you'll see it in some of these. This one was kind of a nail biter because I had to take the celiac right down to the aorta, so I literally figured out a way to side bite the aorta laparoscopically, and then we put in this graft here. Here's one with 3-vessel disease, so SMA encased segment of the common hepatic artery, and then the portal vein. So here you see the IVC in the back with the left renal vein here. Here I'm just taking some of the nerve sheath from around the base of the SMA, just making sure we were going to get negative margins if we transected it. Here's just the segmental resection of the common hepatic artery. I was able to just bring this back together. Do this with running 6-0 proline suture for an artery. Typically we'll pepper and flush all of the arterial anastomosis. I don't always do that for the veins, but every vascular resection the patient gets 5,000 units of intravenous heparin for the case, and then the arteries we flush. Heparinized saline as well. So this is the segmental. Trying to figure out which vessels to do first to try and minimize clamp time is always a bit of a challenge, but started with the common hepatic, make sure we had good blood flow into the liver, then went to the portal vein, and SMV, and this was like a 10 centimeter segment, so this was, I think this one, very long, synthetic graft again. So then we're letting the common hepatic, provide blood supply to the liver, and then we'll get this vessel reconstructed, the superior mesenteric vein and portal vein, and then work on the SMA. So we want to make sure we've got really good outflow before I do the SMA and then unclamp, because if I did the SMA first and then had a long venous outflow clamp time, I'd be worried about obstruction. So here's just this synthetic graft. A little bit. And then to the SMA. So what we do with the SMA is the celiac and the splenic artery were not involved in this patient. So what we did was we just harvested the splenic vein off of the pancreas and swung it down. So we would only have to do one arterial anastomosis. So here you see clip going on the proximal SMA right at the aorta. And then the middle colic artery actually was involved with the tumor. The origin of it, which you see is that stump right there, wasn't, but we had to ligate the middle colic artery because of its involvement up into the tumor. And then this is the final resection. Now we've got the specimen out of the way, and then we just bring that splenic artery and transpose it down there. That's a really gratifying way to deal with the SMA if you only have one anastomosis, especially laparoscopic, where, as I mentioned, the clamp times are just longer. There's no way around that. Well, there should be. I'm still working on it, but I haven't found one. It still takes longer than open. So here's the 3-vessel reconstruction. Do ultrasound on every case, make sure we've got good flow. This patient, negative margins, negative lymph nodes after 6 months of neoadjuvant chemotherapy and radiation therapy. It's pretty gratifying when you see the survivors of these. So anyway, this is the completed project. And as I said, this is what we're doing open as well. So it's just important that if minimally invasive is really going to be a thing, I think we show that it can be done for all, and we've had a really good experience with that. One more, because it's not all about vascular resection. This isn't truly divestment. It depends on how you define divestment. It's hotly debated. I'm not talking about an arterial wall divestment of the adventitia. I'm talking about just taking the nerve sheath. And I'm a big proponent of that because I've found that most of these cancers that look like they're encasing or abutting the tumor are not invading the adventitia of the vessel. It's in the nerve sheath, which is where tumor likes to go. And frequently you can get under that nerve sheath and not have to do a vascular resection, which an SMA, which makes the mortality rate, as we talked about, 4 times as much. So this is a patient that had significant involvement in the SMA well below the middle colic artery origin. And so the first step is we just go at the base of the mesentery below the colon, the mesocolon, and just start the dissection. These are this is the second jejunal artery branch there. I ligated in the vein. But we start distal to where we see on the CT scan and then start take a nerve sheath and we biopsy. And as long as we can do that. What I didn't spend time on the CT is this patient wasn't completely encased. It was about 270, and so kind of at the 10 o'clock position looking from the feet, there was no obvious tumor there. And see, that's why you see me at the 10 o'clock position cutting the nerve sheath and peeling it back. So we start below, make sure it's even possible. Everything proximal was going to be possible. The only thing that would have made us not go ahead was that distal extent, but it was good. So here we're just, again, taking the nerve sheath for this section. Now, it turned out all the margins were negative. The nerve sheath margin, we inked the inside that was touching the vessel so they could look at that and make sure that's all negative. And so this patient, which could have easily just as had an SMA resection, was able to just have a dissection and then needed a portal vein resection. But I think this works really well. Probably all of you have heard. There's no doubt with an SMA resection or even a complete nerve divestment there, especially in women, these people can have some issues with diarrhea and nutritional problems. Most of the time we can get them through it. We can get them to where their quality of life is excellent. It's pretty uncommon that it's debilitating, but that is a risk, and every patient needs to know that. So this is just an end-to-end vein. You can tell this one's a little tighter than most, but as long as I can get them together. One thing I'll point out with this, though, I've learned, I don't convert as much anymore, but early on when I was doing vein intersections, sometimes I just couldn't get it together, and I would convert and then open. It comes together really quite easy. I don't know if it's just the pneumoperitoneum, the way we've got everything exposed, but I cannot pull together a vessel as well laparoscopic. I can't close the distance with an end-to-end as well laparoscopic or robotic as I can with open. And so it's a little different. This looks a little tight, but when the pneumo's down, it looks really good. But I learned that. So over 5 or 6 centimeter length of a segmental vein resection, I can't get that together laparoscopic, where you can do that open, not infrequently. So future direction. I think the future is minimally invasive, absolutely for sure. No offense to those that are doing open surgery. I think our time will end as the new generation comes in and they demand and will do these. Probably not laparoscopic, but robotic. There will probably maybe always be a subset that's going to be done open, which is going to be a problem in the future if we're all minimally invasive. But increased use of vascular resection is definitely possible. There's more groups dabbling in them, but there's very little data on minimally invasive vascular resection for pancreas. Growing a little bit in the vein, but the arterial is very, very small. But I think really where the future is the enhanced robotic platforms. Remember, in my opinion, the robot, even the X5 currently, is nothing more than a sedan with power windows. It doesn't really add anything to the patient. It makes it easier for the surgeon to do things, but it doesn't really add value. But it is the platform for the future of augmented reality, AI, molecular targeting. Some of that could be done with laparoscopy. It's going to be a lot harder. It's going to be a lot easier to scale this with a platform. And so I do think that robotics is definitely the future. So kind of summary of pancreatic resection, minimally invasive. It does have advantages over open, length of stay, pain, blood loss, whatever you want to. We've shown that over and over in our practice at Mayo as well. Both laparoscopic and robotic approaches are feasible and safe. Not much data, as I said, for the minimally invasive vascular resection. Robotic approach, get my bias, you can tell I'm trying to sway you, but it's really for the surgeon advantages, and I don't think that's a reason not to use it. I promote it. I use the robot mostly to train the residents because it's easier to teach than laparoscopy, but we just need to be realistic that it's not really adding a whole lot over someone that's experienced in laparoscopy. Question of laparoscopic versus robotic is really about surgeon ability. It's not anything really about the equipment. And then, it'll be the platform. So it is coming and it will take over, but it's been really fun to help move pancreas resections along, minimally invasive. I think it's a great pattern for anywhere. I mean, if we can do this kind of thing here as has been shown in esophageal and others, there are other areas, minimally invasive surgery can and will take over ultimately. Maybe not trauma. At least I think is safe. Maybe is trauma. We can control elective diseases, maybe elective problems, but people doing the crazy things that brings them in for trauma. That's always that one I think is safe for a little bit, although they're using robots in trauma and acute care for sure. But for some trauma, I think will always be safe. Anyway, thank you very much.
I wonder if you could, thank you for a great talk. And it really is kind of impressive to see what you've been doing. I wonder if you could comment on a couple of things. One is the learning curve. Because I think one of the challenges for particularly the more complicated resections is you've got to be at a center that has a high enough volume that you can have the repetition of cases so that you can get over the learning curve in less than 5 years. And I think that's a big challenge across the country. I think there's going to be hotspots of minimally invasive procedures that will slowly percolate into smaller communities. But I know, we have people that are, they see the advantages of minimally invasive surgery and they start doing these procedures without really thinking about the fact that the outcomes are really poor. When you talk about minimally invasive outcomes, you're talking about the best people in the world reporting their outcomes, not the surgeons across the country. And that's been borne out in population studies as well, that you look at globally across the country, the outcomes from minimally invasive pancreas surgery are never as good as what the best centers in the world are publishing. So that's one issue. And the second is, I wonder if you could just comment about sort of centralization of care. Do we need everybody doing this? I think there's a niche, but even at Mayo, I'm not sure. Are there other people doing robotic Whipples?
Yeah, really great questions. The first one is fascinating. I've got a whole talk just about that. The learning curve is a troublesome factor for me because I in some ways I disagree with people publishing a learning curve and assuming that applies to everybody and that's what you should bank on. The learning curve is entirely dependent on the surgeon, their MIS experience, the volume, as you said. It's so many different things. You can't take a learning curve from Pittsburgh and then say I'm going to do this in Buffalo, Minnesota, and I just need to do that many. It's a problem. I do think it's a bigger problem for laparoscopy because there's no doubt in my mind the learning curve is longer. Like I said, I was blessed, fortunate, whatever. I fell into a practice where I was doing 2 bariatric procedures every day in addition to my Whipple and my liver, and so I was sewing all the time. So my learning curve was very different once I started doing lap Whipples than I think anybody else's would be unless they had that same sewing experience. Because I was doing open Whipples while I was doing lap bariatric surgery, so I had growing experience in minimally invasive and pancreas surgery. That's very uncommon. With the robot, I think the minimally invasive skills will come easier, but it's still a learning curve. And if you do the math and say, well, my institution, wherever I'm at, we do 10 Whipples a year. If the learning curve is 40, first of all, you have to assume that you're going to hit it at 40. Second, you have to assume you're going to get every one of those Whipples. Not every one of those Whipples is the ones you should start with, which leads me to the point number 2, if it's more complicated. So I think it's a real problem. I don't want to promote centralization of all care, but I think there's certainly some of these borderline and locally advanced, I think probably should go to a tertiary center, personally. You could argue that a little bit. It depends on how well you're trained and then where you are and what kind of a team you've got. But if you're doing that once a year, a vascular resection, I don't know. I don't know if that's what you should really be doing. If you're doing enough Whipples and distals, then sure. I would say technology is probably going to help the smaller, the lower volume settings in that once we get the latency, and I think we're getting closer, but you could maybe pipe into somebody. So maybe you could do a lap or a robotic distal or a robotic Whipple if you've got all the experience and all the credentials and the hospital support. But if you need help, you have somebody remote in and help you. I mean, that may be a thing in the future. So because I can tell you, the patients that come and see me from lots of places, they're like, I didn't really want to come to the big city of Rochester. Couldn't I just have this done in Mankato or, somewhere else? I don't want to travel to the big city. I hate the big city. And I don't think that's going to change over time. People want to get care locally. But it'll be a really tough thing because just because a general surgeon can dock a robot, has never done a Whipple, should somebody be trying to pretend like they can do a Whipple from, Boston in Mankato with a general surgeon? That's not putting anybody in a good position. The general surgeon, not in a good position if something bad were to happen. So it's complicated. I think ultimately some of this stuff, is just for places that are doing a lot of volume. And I don't know what that volume is, but let me give you one more example. To your point, 10 years ago or so, the National Cancer Database was picked for evaluating laparoscopic versus open Whipple, and they showed that laparoscopic Whipple mortality was significantly higher. And then when they got a lot of flack from people that like laparoscopy and pointed some things out, they went back and looked at it, and they included everybody. So what it was the small hospital that does 3 Whipples a year trying to do laparoscopy because all their Whipples were now going to the bigger centers, and they didn't want to lose the cases. So they kept them, tried a lap Whipple, the patient died, and then they maybe did one more, and then it went into the database. But what they did was when they went back and looked by volume, then there was absolutely no difference in mortality rate. And I want to be very cautious with that number. It's not just the volume. And I always say that even if I, with my experience, went to a smaller hospital without the salvage capabilities we've got, with great IR and great CT scans and everything, I wouldn't have the same outcomes. So we need to be careful about, just because you're trained well, volume isn't the only thing to worry about. Is the hospital ready for something like that? But I think, distal pancreatectomy, whether Whipple's going to be included in all those, but I think distal pancreatectomy, if they're good, minimum invasive, and they understand the anatomy and they've had great training, I think there's a role for that in even smaller hospitals.
To that point, your team that you have, how much is it consistent? Do you have, roughly the same scrub techs, same anesthetic team on a week or month to month, whatever it might be?
Yeah. If you'd asked me pre-pandemic, I would tell you I was the luckiest surgeon in the world. I had the exact same surgical assistant for every one of my Whipples. Even if I stayed late and did it till midnight, they would stay with me. And the nurses in the room, it was all consistent. We've had our shortage of staff issues, and it's not quite as good, but I'll tell you, it's not quite as good from my experience before, but that's an important question because I do have a team that does lap Whipples with me every day. I operate about 90% of the time. So that's a huge difference. And I could show you many of the shortcuts I've found to make the operation easier, quicker, safer have come from my surgical team. Saying, hey, Dr. Kendrick, don't you think you could do this? I see you're frustrated on this part. And they just speak up, and I'm like, well, no, I don't think so, or you're brilliant. That's amazing. And I've got probably 4 or 5 things when people come watch Whipples, I point those out to just show the team made a big difference. So.
Got a lot of trainees in the room. Maybe none of them ever want to see those videos again, and maybe some of them want to do that. How are trainees involved? How are trainees preparing themselves in a simulator or education? You've won Teacher of the Year, and you're doing incredibly complex stuff only a few people in the country are doing. How do they participate?
Yeah, it's good. So it was when before the robotic became so popular, a lot of the residents were getting a fair amount of laparoscopic experience. Not much sewing, so it was always tough. So on my service, they learned how to sew. That's kind of the contribution. But one of the reasons why I am doing the robot more is not because I'm convinced it's better. It's actually slower. It takes me an hour longer to do a robotic Whipple than a lap, even after doing hundreds of robotic cases. But the residents get so much more out of it. And I was telling somebody at dinner last night, I mean, we have, I just never forget, I keep talking about the same resident, but I had a resident, I was going to have him sew up the duodenojejunectomy in a laparoscopic Whipple. It took them 30 minutes, it seemed like 4 hours to me, to put the first stitch in, tie the knot, and just make the first throw of the needle for the duodenojejunectomy. And my duodenal ulcer was bleeding. I had to go to the ER. No, it wasn't quite that. It felt like it. The next week we did a robotic one, and the same resident sewed up a duodenojejunectomy in like 15 minutes. The whole thing. It's just easier. And so I'm kind of conceding a little bit because I don't think laparoscopic complex stuff is going to continue to exist. It should exist in small communities and for some procedures. I'm totally against, shouldn't say this out loud. I just think robotic gallbladders, I think we've screwed up a really simple operation. If you're doing robotic gallbladders because you want robotic experience so you can do more, I get that, and I'm totally for that. But to let intuitive tell us that every patient should have a robotic gallbladder to me is a little bit silly. But anyway.
I agree with that 100%.
Good. So I just want to finish the point. So the residents, get as much robotic experience as you can. It's the future. You're going to do it. Definitely enjoy and learn everything you can from anything laparoscopic and open, because I think no matter what, you're a better surgeon if you can understand it, no matter what the approach is. And so you need that. And you might need to convert. Anyways.
You had mentioned that there was 1 or 2 cases maybe that you wouldn't start laparoscopically. Remember what the reason for that was?
Yeah, I do, because it's very rare. One had an ileal conduit on this side and a colostomy on this side, and they had gastric ulcer perforation with Billroth 2 and leaks, and so that was one I just set up. I'm just not going to play around with that. Another one was a patient that had, I think, radiation a year before they came to see us. So they were told they were unresectable. They got chemotherapy, got radiation, and a year later they're on like this low dose of chemotherapy with everything stable. And they had complete encasement of the SMA. And those radiated fields, especially the longer out you are, could I have done it? Maybe, but that it just didn't seem like the thing to do. So it's pretty rare. I'll plan on it. I'm not, guess you'll be the judge of hearing me talk for the last hour. I'm not arrogant. I don't mind. I just take everybody to the OR plan for laparoscopy. If I think it's not going well, don't have surgical momentum, it's dangerous, my assistant's not having a good day, we just convert. I don't have problems. It's rare, but I don't have a problem with that. I would never. Matter of fact, I really have a bias. I hate papers about conversions because I think what it does wrong. It convinces people that it's bad, and so they never want to convert because that looks bad. So now they're going to either try harder, and then there's going to be a really bad outcome. I mean, convert. I look at it like you're an open surgeon and you have a right subcostal and you're trying to do a bile duct resection or something. And you just don't have the exposure and you can't get to it, so you extend the incision. That's a conversion, right? I mean, you're making a bigger incision. I think conversion is a no-brainer. Of course, if you look at the patients that are converted after minimally invasive approaches, the complication rate is going to be higher. Well, that's why they converted. It was tough. When you compare it to all the open cases, it's going to look, you compare the converted MIS cases to the open series, and it's always higher because you're lumping in all the easy open ones. What about how do we flush out the ones that were just as bad and would have led to a conversion had it been done minimally invasive? See what I'm talking about? So I think conversions are a good thing. I promote them, especially early. If you're trying to do something minimally invasive and something doesn't seem safe, convert. The patient will forget the length of the incision. They won't forget the T-tube you've got in or the other operations you had to do to fix the problem that you generated.
Hi, Dr. Kendrick. I'm one of the chief residents. Thank you for that excellent talk, and the videos were very amazing that you had. I had a question about like the complex vascular reconstruction and locally advanced and your decisions for like when you deem a patient when you're in the operating room and just really think that it's truly unresectable. And then my second question is the outcomes regarding the like complex SMA and celiac reconstructions. Just for me and my board preps as I'm keeping like all of the NCCN guidelines in mind, just like how those compare to the like other patients.
So I will give you the pearl for your boards. Do not tell them you do a vein
Yes, yeah.
or an arterial resection, no matter what the approach is. That is not what they're looking for somebody they want to come fresh out of residency. I would say in a tertiary center with experienced people, that may be possible, but I would not, that would be unresectable for me. Do not go there. We're doing a lot of it, and I would tell you everything that we've either published or will be publishing, the results are just amazing. And most of that's neoadjuvant. So let me tell you, the results are amazing from an oncologic outcome, partially because we're biasing ourselves up front. We're making all of our locally advanced patients go through full 6 months of chemotherapy, and they have to have either normal or very close to normal CA19-9. Then they get radiation therapy. So number one, you're kind of selecting out the good biology, right? Because we're not perfect at anything we do, but if they respond well to chemotherapy, they get radiation and we go. The margin negative resection rate's now at over 90%. The early recurrence is half of what it was before. The complication rate of an arterial resection is higher, no doubt. Oncologic outcomes are no different, which is amazing. So if you have a patient, right now we've got some data we'll be publishing, but if you have a patient that gets neoadjuvant therapy, normal CA19-9, radiation, whatever sort of pancreatectomy with vascular resection you need to, 5-year survival is 40%, which, I mean, that's ridiculous. I mean, we've never seen that before. But again, that's not because we're being super surgeons and doing these amazing things. It's the biology. And that's why I try and convince my colleagues who are convinced that, that neoadjuvant is so important. Well, neoadjuvant is important, but it's neoadjuvant is important because you're selecting out the patients that don't respond to chemotherapy and have metastatic disease already, right? We know that most people, probably all patients that we see with pancreas cancer have metastatic disease. It's just whether or not the cells are going to survive or not, or you can kill, neoadjuvant therapy. But I would say oncologic outcomes look extremely good, and that's been shown for decades with venous resection. We're now showing the same thing with arterial resection. And the outcomes, the complications are higher, for sure. So it comes down to a big discussion with the patient, especially the SMA resections. Higher mortality rate, possibility of significant diarrhea, nutritional problems. It's a good question, and that's why not every center is doing them. I'm not saying everybody should. We're having a good experience, and we'll keep publishing until we get to the point where we think we've got enough numbers that's meaningful. Right now, when you publish 50 or 100 or 150 arterial resections, I don't know what that means. I mean, that's still pretty low numbers for true statistics and good clinical.
I'm Rachel. I'm actually one of the vascular surgery residents. So it's been really interesting to see your work. I think kind of similar to what you mentioned when you were starting your training, I've heard a lot of talk of like hybrid vascular procedures or laparoscopic robotic, and a lot of people say it can't be done, but you're doing it. So that's pretty cool. I was curious if you had, or what your contingency plan is. I think one of the things that I've heard that scares people is how quickly a patient can decompensate with uncontrolled hemorrhage. And so what's your contingency plan in a minimally invasive environment?
Really, really, really great question. I will honestly tell you, I have had less catastrophic, alarming, gut-wrenching bleeding laparoscopic than open by far. I'm a big believer in the pneumoperitoneum and venous bleeding. I think that's one of the reasons why minimally invasive surgery has less blood loss. Number one is magnified, so you're freaking out over a teaspoon that looks like a gallon, looks like a liter of fluid of blood. But the pneumoperitoneum, I mean, sometimes we'll have a little avulsion of the, maybe the anterior superior pancreatic duodenal vein or something that in an open case usually bleeds pretty briskly. And laparoscopic, it like bleeds a little bit, and then you grab it. And I'm not saying it's safe, but my contingency plan is important. Number one, you have to know where to expect the problems. And this is where experience in HPB has to trump minimally invasive skills. A minimally invasive surgeon with no HPT experience should not be doing this. And that's because you need to know where the problems are. Where is that vein that we name because we have problems with it? Where's the IPDA coming off, the SMA? The current imaging is so good. I know from the CT kind of where I'm going to have trouble or not. Most of the time, I have a Raytech or a sponge in the belly. We have the ports are all 12s. So, some people are saying, oh, well, I can do 3 12s and I do 3 5s. I'm like, good for you. I don't really care. I put 12s everywhere so I can get a sucker, a stapler, a clip, a sponge, anywhere I need to, because when you bleed, it's not always a convenient time and you need to be able to just put pressure. But what I found over time is you can just put a Raytech on a bleeder, even a big one. And most of the time, you're controlled. You don't need to freak out. You definitely don't want somebody putting the sucker in the portal vein and making it bigger. I've had people help me with that a time or two. Because the first response with bleeding, right, with the person holding the sucker is, I got to control the bleed. And now you take a 2 millimeter venotomy into a 1 centimeter venotomy. So it's just pressure and just relax. Just take a breath, talk to anesthesia, hold the sponge there, do a conversion incision, or if you think you can put some clamps in there and safely just oversew, you can do that. But knowing where the problems are going to be, because there's probably 3 or 4 places on a Whipple that if you're getting in trouble, it's going to be one of those 3 or 4. You don't usually make up new places most of the time. And then just being prepared. Sucker, insufflator, high flow. Sometimes we'll have 2 suckers. Sometimes we'll have 2 inflow. But that's pretty uncommon anymore as we've gotten more and more comfortable. So pressure works really well in laparoscopic cases. Anyway. Great.
Thank you.
Certificate of appreciation for being here for the Judd lecture. Thank you again.
Been doing 8-hour surgery for
We're going to take a moment. Dr. Balahati is going to talk about her experience in Saipan for global health.
the guy that just got I was like, back. Serious?
Was it?
So bad.
This is fun. Yes, I know.
Terrible.
It seems impossible. Yeah. Sounds nice. So annoying.
How are you? Ben, we're going to go on hospital.
You can always practice like suture. It sounded like a fun wedding, you know? There was something in Vegas.
Yeah, maybe I'll start with pieces. I'm like, they're really
It is like you have to.
yesterday. I don't know.
Well,
Hi everyone. I'm Maria Baldwin. I'm working at Victoria. Hey guys. Just giving a brief overview of my global health rotation in the Commonwealth of the Northern Mariana Islands, which is where I'm from. Just a little bit of background on the CNMI. It is a U.S. territory made of 14 islands, but only 4 uninhabited. We have 1 state hospital on the island of Saipan, which is where I grew up. Pretty small, 86 inpatient beds and 4 ICU beds. And then just a brief description of some of the demographics of the patients we serve there. Our poverty line, our 38% of the population does live below the poverty line, which is about 28% higher than the U.S. As a whole. Logistics-wise, I had a 7-week rotation. It took me 24 hours to travel, but because of the time difference, I actually left on a Monday morning and got there early Wednesday morning. And so that was 3 days into my first week. I was fortunate enough to stay at home and was provided with transportation. I was assigned 1 preceptor, but there were 4 general surgeons that I got to work with. I took 2 24-hour call shifts per week, and I saw all of the patients that I saw on call or operated on, and then did elective cases, add-on procedures, and bedside procedures. Just a few photos of this is the hospital outside, some of the OR pics. This is a photo that we had to take out one Friday night with one of the general surgeons. And then I thought this was kind of funny because it's the call board and the ED, so they listed me as on call. Unfortunately, 3 weeks into my rotation, we did get hit by a Category 5 storm, which was Super Typhoon Senlaku. It lasted 3 days. It was about 175 to 180 mile per hour wind, and Hurricane Katrina, just comparing that, was 160. I do have videos, I think, if they show up. That's fine.
Are either of you two able to help her try and get the video?
That's okay. I will just
See there.
show photos.
No, I
This
wanna
is
see
the
it.
damage around my house.
You want to see the videos?
Oh, okay.
Get out.
You don't experience
Act
them.
it out today. Dance.
So I did a
In the fan.
it probably did not
Yeah, it's just-
translate. Anyway, that was like the most interesting part of my presentation. But that's okay.
Where's the WhatsApp?
Yeah. Text it to the group.
Oh, this is a still shot of the hospital. During the storm, they were trying to scoop out some of the water that was flooding in the hallway. And then this is outside of my house. I was very fortunate that I didn't have any damage to my home and my family was safe. This is a picture of my dad. We were hiding in the hallway because even though our windows were shuttered, it really felt like our windows were going to blow away. And then we also didn't have power for about a month. The hospital itself was on and off generator for about 3 weeks. I think the scariest part, besides the strong winds, was that we lost our sole communications tower. And so we weren't able to get updates throughout the storm until things had cleared about 3 days later. And now, 2 months later, a lot of people, I think 60% of the islands don't have power still. In terms of medical care, though, we did receive a lot of NGO help through Samaritan's Purse and Team Rubicon, so we were able to provide inpatient services or service to our people. Some of the things that they were able to do here. And then, of course, the Red Cross was a big part, and I actually met Dr. Brunswell's partner, Barb, who was providing mental health services through the Red Cross in the shelters. So I missed about a week of the rotation because of the storm. Unlike here, I probably would have had to come into work if there was a storm, but stay off the road. But when I did get back to work, this was about, I tallied up my case log for the entire rotation. I got about 57 procedures and surgeries. Endoscopy is actually a really big part of their practice, but as you can imagine, trying to do a bowel prep while you don't have power or water is not very pleasant. We do have a lot of dialysis access cases because we have a high incidence of ESRD. And then one of, I think, my favorite procedures was a burr hole because we don't have a neurosurgeon on island. There is one on Guam that may occasionally fly with the Coast Guard if it's needed. But sometimes the general surgeons are comfortable with it and they'll do a burr hole if it's needed emergently. And then we were also podiatry. So a lot of wound debridements, especially after the storm, people with uncontrolled diabetes who were trying to clean and got their foot wet and they had like some small wound before the storm and then it escalated into NSTIs. I did about 4 BKAs. I had never done a BKA actually here, only AKs. So I got my experience there. And then quite a number of chest tubes. I did one in a peds patient, and my attending had never done a pigtail before, but he said he'd just watch me and supervise. So that was interesting. These are pictures of some of the people I grew up with that also work at the hospital. So I think one of the nice aspects of being home was just seeing everyone that I knew. And then my brother is actually a Catholic priest, so he was a chaplain one day, and my patient actually requested the chaplain to be there for him before he had to fly out to Guam, another island, for more advanced medical care. And my brother was the one that responded. In terms of my experience, so I think the attendings were really eager to teach. They had never had a resident before, but they, were really good about teaching in the operating room, and then just teaching me about kind of like how things run in the hospital. Some of the differences from training so far compared to the cities or the Twin Cities is, we get consulted on anything like urology related, podiatry related, because there's no other surgical services besides us and like one orthosurgeon. We did manage a lot of neurocrit patients in the ICU because of traumas related to the storm or assault related traumas, which I feel like we don't get a whole lot of experience here. Again, a lot of vascular access, and then there was no trained scrub techs, so there are nurses that worked in the OR, but they weren't actually formally trained, and so that was also a learning curve for myself in the operating room, trying to figure out how to describe what I wanted when I was asking for it. And then I think a biggest part of healthcare in a rural and remote place is trying to figure out where you send your patients if they need something more than what you can offer. We did have one patient with cholangitis and choledochal that I think historically the surgeons did do common bile duct explorations, but they had strayed away from that, and then they just send their patients to Guam, where there's a GI doctor, and then they can see both GI and surgery on a different night. From a personal perspective, I actually didn't realize how nervous I would be treating people that I grew up with and that I saw in my own community. People that had, even if they were older, they knew my parents, and so it felt like the stakes were higher. So that'll be an interesting thing to tackle when I'm back home eventually after residency. In terms of feasibility, I think being on a U.S. territory does make it easier to travel to. There's probably less restrictions. And there are also other residency programs that send their residents there. And in fact, I was inspired to do this because one of the PEAS residents from the U actually did a rotation on site camp. And so I got that idea as an intern. I emailed Dr. Tuttle and he was on board. So I'm very grateful for that. In terms of housing and transportation, obviously I was lucky enough to stay with my family. So it might be more difficult finding those things for another resident who may want to travel there and do a rotation. But I do think we're a pretty interdependent community, so we rely a lot on each other. And, I'm sure there's some sort of setup that we could find for future residents. And just to end, maybe I can go back to the videos after this, but I just wanted to thank everyone, especially Dr. Tuttle, Stephanie Woods, Dr. Kendrick, Dr. Brunswold, and Jessica Anderson, who have all been supportive of this rotation. And then the people that aren't here today, but people from the hospital that I worked at, especially the surgeons and the OR staff that I got to know really well. And then to everyone, my co-residents who checked in and donated after the typhoon, I'm very grateful. Thank you.
Maria, I have a question.
Yes.
Thanks for telling us about your rotation, and hopefully that inspires other residents too to continue these global surgery electives and be creative with your options. For the choledochal patient that you guys sent to Guam or some of the neurosurgery patients, were there other cases that you guys would typically send elsewhere? Because I'm thinking when I went to Shiprock, and we even had some NSDI patients that we would send to another hospital because they did not have CRRT capabilities and really intense ICU capabilities. So it made me really appreciative of the outside hospitals that previously I had been why did they not operate on this? But
yeah, I guess we didn't actually have anyone in that got that sick that we couldn't manage, and I feel like our anesthesia team was actually very comfortable with managing sick patients. I do think a lot of the providers in the hospital are all kind of working outside of their means, and you kind of just do whatever you feel like you have to do to help the patient. So that was, but I don't think we ever had anyone that like needed CRT and couldn't get it. We did have one patient with a non-healing foot wound that had peripheral artery disease, and we don't have any IR capabilities, no vascular surgeons on island, so we actually sent that person to the Philippines to be assessed there. We like took care of the wound, and then we were able to have them. We actually discharged them because of the way their insurance worked. So they had to like be discharged the morning of their flight, and then they went straight to, I think, a hotel and then the hospital within the same day that they got to the Philippines. Yeah. I'm curious to see if there would be more if the storm hadn't happened. I'm sure more people would have come in for different things, but people are pretty apprehensive about healthcare. They don't like to know if they're sick or dying, and that ends up leading to a lot of problems later on.
Say a couple of words. Thank you, Maria. That was your presentation. The timing of your presentation, I think, was spot on. We just heard this brilliant, high-tech talk about doing arterial resections for pancreatic cancer. We're in very few places in the world. And your presentation. And this, for most of the world, this is what surgical services look like, and I really appreciate your willingness to go there, survive typhoon, and we now have, for our surgical residents, we have 4 approved rotations that you can participate in. Thanks to Maria, we have the Northern Mariana Islands, we have Uganda, Dr. Rickard has leading rotation in Rwanda, and after a long absence, we finally have an MOU again with the Northern Navajo Medical Center in Shiprock, which is a great experience. As Anna talked about, one of our former residents, met with her in May. She's on staff now at Shiprock. These experiences, I think, really help our residents see what surgical care looks like for most of the world, particularly in poor countries. If you want to do a rotation, these are 6, 7, 8 weeks, depending upon travel. If that's too much for you, you just want to dip your toe into global health. I go to Honduras multiple times a year. Dr. Chipman, Dr. Beelman go to Uganda every fall. Let us know if you're interested. Can you do the next slide? So these experiences aren't free. Airline tickets are more and more expensive, so we are constantly fundraising for these experiences for our residents. And so our next global surgery fundraising event is Friday, October 23rd at the Hall of Kings. Is a new venue for us. It's really cool. It kind of looks like Game of Thrones type of place. We'll have a band. We'll have a couple of speakers. It'll be a lot of fun. But keep this on your radar. Thank you very much.
Maria?
Yes.
Nice to see Steve Argo's name.
Oh, yes.
Live in the Navy. I see he's doing a lot of overseas care.
Yeah.
Las Vegas. Yeah. He was
Well, third year.
Just a year away.
Doesn't make sense.